Good morning, everybody. It's 7 o'clock. It's time to get started. It looks like we do have a quorum. Dr. Robinson has asked that I conduct. He's on the meeting, but he's asked me to conduct today, so I'll be doing that. So first item of business is to review the meeting minutes from the November meeting. And actually, before we do that, I just want to remind everyone to let us know you're here. If your name isn't associated with your picture on the screen, please email us or say something in the chat. Email is medicaidpharmacy@utah.gov. And if you're joining us by telephone only, please let us know that you're here, just your name and your organization, so we can keep track of that. Remind everyone to keep their devices muted unless you're speaking, and can always use the chat on the right side of the screen if needed. To mute, there's a microphone down at the bottom. When you click on it and when it's red, it's muted. When it's white, we can hear you. All right, so I'll go ahead and proceed with the review of the minutes. Do we have a motion to approve or modify any comments on the meeting minutes?
I'll move to approve, Brian.
Thanks, Michelle.
Second.
And who is that?
That's Chris Valentine.
Thank you. All in favor? Say aye.
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 Any opposed? And any abstaining? Okay. Motion passes. The minutes are approved. Next, we'll get a DUR board update from Noon.
Thank you, Brian. So DUR board met in December and January to review a newer antipsychotic agent like Grayflar and another one. And we met in just last week for the February DUR to review an ADHD edit that's going to be implemented in April. It's including the concurrent use of amphetamine and methylphenidate. Also restricted the use of more than 3 ADHD stimulant medication at once. And DUR board going to meet next month, also to review and establish prioritization criteria for CGM as well. Thank you.
Thanks, Noon. Now we'll get started on our review, the continuous blood glucose monitoring with Elena Martinez.
Hi, and good morning, everybody. Let me share with you the slides I prepared. Yeah. Can you all see the slides?
Yes, thank you.
Yes, thank you. Okay, glucose. Let's see. Yeah, glucose variability is associated with diabetes complications. Chronic hyperglycemia can lead to microvascular and macrovascular complications, such as retinopathy, nephropathy, and stroke. Severe hypoglycemia is the most worrying acute complication in the management of diabetes because it can lead to unconsciousness and death. Conventional self-monitoring of blood glucose using finger stick testing plays a key role in glycemic control for patients with diabetes who are receiving insulin or who are pregnant. However, it has limitations such as inconvenience, discomfort, and inability to provide a comprehensive assessment of glucose trends and alerts for hypo and hyperglycemia events. Continuous glucose monitoring, referred to as CGM, devices measure interstitial fluid glucose levels continuously and provide more extensive data regarding glucose levels, glucose fluctuations, and hypo and hyperglycemia episodes. Personal CGM systems are owned by the patient and consist of a sensor that continuously measures glucose levels, a transmitter that collects and transfers glucose data from the sensor to the monitor, and a personal monitor such as a device, a specific receiver, a smartphone, or insulin pump that displays glucose readings. These devices can help patients with diabetes mellitus achieve personal glycemic targets, such as an improvement in hemoglobin A1C by increasing the patient's time in target glycemic range and reducing the time in hypoglycemia or number of hypoglycemic episodes. Personal CGM systems can be classified as real-time CGM, referred to as RT-CGM, or intermittently scanned CGM, referred to as IS-CGM. RT-CGM systems continuously display real-time glucose information on a personal device, and these include Dexcom, G6, Guardian Connect, and Eversense. IS-CGM systems display glucose data only when the user scans the sensor, and these include Freestyle Libre 14-day and Freestyle Libre 2. This table displays the main features that differentiate CGM devices, such as age of approval, the wearable time of the sensor, application site, requirement for finger stick calibration, real-time alarm capabilities, adjunctive or non-adjunctive use, and compatibility with other devices. CGM devices are approved for the management of patients of varied ages with diabetes mellitus. Dexcom, G6, Guardian Connect, and Freestyle Libre 2 are approved in the pediatric population, with Dexcom G6 indication covering the youngest population, 2 years and older. CGM glucose sensors are inserted subcutaneously by the user, except for the Eversense glucose sensor that is implanted under the skin by a healthcare professional. Eversense and Guardian Connect require ongoing finger stick calibrations at least twice daily. Dexcom G6 and Freestyle Libre systems do not require finger stick calibrations. Real-time alarms available in RT-CGM and Freestyle Libre 2 systems are a key safety feature to alert users when prompt action is needed to rescue their glucose levels from hypoglycemia. The 3 RT-CGM systems also have real-time predictive alarms to prevent impending hypoglycemia. 2 of the 3 available RT-CGM devices, Dexcom G6 and Eversense, and the 2 IS-CGM devices are approved to replace self-monitoring of blood glucose for making diabetes treatment decisions. Guardian Connect is approved as an adjunctive device to self-monitoring of blood glucose when glucose levels should be verified with finger stick testing for treatment decisions. CGM devices do not completely eliminate the need for finger stick testing. Self-monitoring of blood glucose may be necessary with any device if indicated by the device during the initialization or warm-up period of the device, and if the patient's symptoms do not correspond to the sensor glucose readings. Only the Dexcom G6 and the Freestyle Libre systems are available for use with a receiver supplied by the respective company, whereas the patient must have a compatible smartphone or other compatible smart device in order to use the Guardian Connect or Eversense systems. Systems integrating insulin pumps with CGM include MiniMed 630, MiniMed 670G, MiniMed 770G, and TSlim X2. This table displays some characteristics related to insulin pumps integrated with CGM. Label indications do not specify the type of diabetes except for MiniMed 670G, MiniMed 770G, and TSlim X2 with Control-IQ technology that are indicated specifically for patients with type 1 diabetes. MiniMed 770G indication covers the youngest population, 2 years and older. These advanced insulin pumps use different technologies to adjust insulin delivery and can help reduce self-care burden and incidence of hypo and hyperglycemia while improving overall glycemic control. The newest integrated systems such as MiniMed 670G and 770G incorporate predictive low glucose suspend technology that suspends basal insulin delivery when the sensor glucose level is predicted to reach a pre-specified low limit. They also include hybrid closed loop technology that automatically increase or decrease the amount of insulin delivered based on sensor glucose levels. The 2021 American Diabetes Association, or ADA, guideline recommends both RT-CGM and IS-CGM systems for the management of adults and youth with diabetes on insulin as a tool to improve or maintain A1C and or reduce hypoglycemia. There is higher level of evidence for patients on intensive insulin therapy. There is multiple daily injections of insulin or continuous subcutaneous insulin infusion compared to other insulin regimens. There is also higher level of evidence for RT-CGM compared to IS-CGM. The 2016 and 2020 American Association of Clinical Endocrinologists and American College of Endocrinology guidelines recommend CGM for patients with type 1 diabetes who experience severe hypoglycemia or hypoglycemia unawareness, or who do not reach glycemic targets. And for patients with type 2 diabetes who are on intensive insulin therapy and have high risk of hypoglycemia or unappreciated hypoglycemia. The 2017 International Consensus Guideline recommends CGM for all patients with type 1 diabetes and patients with type 2 diabetes receiving intensive insulin therapy and not meeting glycemic targets, particularly those with problematic hypoglycemia. A specific preference for one brand of CGM device over another is not specified in guideline recommendations. Regarding integrated CGM insulin pump systems, the 2021 ADA guideline recommends use of automated insulin delivery systems in children and adults with type 1 diabetes because of their benefits on glucose control. Sensor augmented pump therapy with automated low glucose suspend technology is recommended in adults and children with diabetes to prevent and decrease hypoglycemic episodes. Selection of integrated CGM insulin pump systems should consider patient preferences, cost, type of insulin, and dosing regimen, and self-management skills. Following a systematic search for direct evidence in Ovid Medline and Embase, only one head-to-head RCT was identified with currently available standalone CGM devices. This study in adults with type 1 diabetes and normal awareness of hypoglycemia demonstrated superiority of Guardian Connect with hypo and hypoglycemia real-time alarms over FreeStyle Libre 14-day system with no alarms in terms of reduction in hypoglycemia and improvement in time in range. This trial suggests there may be advantages with RT-CGM compared to IS-CGM. However, it is unclear if this evidence would extend to the newest IS-CGM system, the FreeStyle Libre 2, that includes optional real-time alarms to alert the user of hypo and hyperglycemia. In addition, comparative RCT data is lacking to determine how other CGM systems compare with each other and how integrated CGM insulin pump systems compare with each other. Regarding comparative efficacy between CGM systems and self-monitoring of blood glucose, systematic review evidence suggests RT-CGM systems are more effective than self-monitoring of blood glucose regarding A1C and hypoglycemia reduction in patients with type 1 diabetes and those with type 2 diabetes receiving insulin. Based on meta-analysis data with heterogeneous populations or study design, there are no differences between IS, CGM, and self-monitoring of blood glucose regarding A1C reduction, but a significant improvement in hypoglycemia with IS-CGM. However, some individual RCTs in certain subgroups of patients have found greater improvement in A1C with IS-CGM versus self-monitoring of blood glucose. Adverse effects associated with the CGM sensor include skin allergic reactions to adhesives, scars, pain, infections, bleeding, imprecise measurements that can indirectly lead to hypo or hypoglycemia, preterm sensor failure, or accidental sensor displacement or fracture. The 2021 ADA guideline recommends, based on expert opinion, assessing and addressing skin reactions due to irritation or allergy for successful use of CGM devices. As CGM devices are being considered for inclusion on the Utah Medicaid preferred drug list, the P&T committee may consider the following suggestion. Consider at least one CGM system as preferred on the PDL, with at least one being a CGM system that has real-time alarms to alert the patient when prompt action is needed, is approved for the pediatric population, and is intended to replace self-monitoring of blood glucose for making diabetes treatment decisions. And for your information, as Noon mentioned before, in March 2021, the DUR board will consider potential prior authorization criteria for the use of CGM devices. Regarding utilization, Among the Utah Medicaid fee-for-service pharmacy claims during the last year, 6 patients received CGM device components that correspond to the Freestyle Libre 14-day system or Dexcom G6 system. Thank you.
Elena? Elena, this is Joe from Utah Medicaid. Question about gestational diabetes. On the one slide, you had recommendations of the types of patients, type 1, type 2, but gestational patients were back, I think one more, gestational diabetes. Is there a place where patients with gestational diabetes might be appropriate, or did you see any literature on the use of these devices with patients with gestational diabetes? There we go.
Well, there's very limited information on gestational diabetes. It's true that the ADA, the 2021 ADA guideline recommends, I think I have it here in the report, let me check it out, recommends CGM systems for pregnancy. So in general, they are really general. So that includes gestational diabetes too. Let me check that. But yeah, the information is very limited, but it's true that there's a recommendation.
Okay. Yeah, you would assume a patient with type 1 or type 2 who is pregnant, sure. I just hadn't seen anything on patients who develop gestational diabetes and whether, I suppose the problematic hypoglycemia might qualify those patients.
Yeah, I agree with that. Yeah, in the ADA guideline, they say when used in addition to pre and postprandial self-monitoring of blood glucose, CGM can help to reach A1C goals in diabetes and pregnancy in general. There's another guideline.
Well, thank you. I didn't mean to throw the discussion off track. Thank you.
Yeah, you're welcome.
Hi, Joe. This is Luis. So in the report that was submitted by you, page 30 talks about that gestational diabetes, that evidence is unclear concerning the efficacy of CGM in pregnant women with pre-existing diabetes, where the studies are ongoing.
Thank you, Luis. Thank you.
This is Brian. I have a question as well. In one of the tables you showed, it showed which devices are real-time, which ones are intermittently scanned. One of them, I think it was the Freestyle Libre 2, says that it's intermittently scanned with an option for alarms. Does that mean it's doing real-time scanning too, or could you? I'm a little confused on that.
So for this Freestyle Libre 2, so the alarm is already set up. You can deactivate the alarm, but if I mean if you need to see the exact glucose level, you have to scan the receiver. You have to scan the sensor with the receiver or their smartphone. But yeah, it will have an alarm if you reach the pre-specified low glucose level. Then it will you will have an alarm, but you have to scan the sensor to exactly see the level, the glucose level.
Okay, but it is doing real-time scanning for the purpose of alarms.
Yes. Yeah.
Okay, that's good to know.
So it has it has the real-time alarm. Yeah. So that's the new thing for this device.
Okay.
But the Freestyle Libre 2 does not have the iOS mobile device, or they don't have mobile devices yet. It's not FDA approved, I believe.
Yeah, that's true.
Oh,
it has the receiver, only the receiver, right?
Yeah.
The reader, yeah.
Okay, that's good to know too. Thank you. All right. before we get too far into discussion, why don't we move into public comment and we can return to the discussion. First up from Medtronic, we have Emily King. So let her speak. Just a reminder that you've got 3 minutes and time is yours.
Okay, perfect. I'm actually going to have my colleague Brian Olivier pull up some information and share it with you. So, of course, you guys spoke to the Guardian Connect CGM and our Guardian Sensor 3, which is compatible with not only our insulin pumps, but now our smart insulin pen, which is what Brian's going to speak to today, just in it being a new alternate for insulin pumps and for injections for patients taking mealtime insulin.
Thanks, Emily. Can everybody hear me and see my screen?
Yes.
Okay, great. So we just want to provide, like Emily had said, I'm Brian Olivier with Medtronic Diabetes. Just a quick introduction to the InPen smart insulin pen. So if we look at insulin dosing today, obviously there's been a lot of new technologies launched, all the way from insulin pens into insulin pumps. But due to several factors, including convenience, cost, and complexity, so there are times where insulin pump therapy at the right side of the screen here is just not available, or the right therapy for all patients who are taking insulin. And still today, the vast majority of insulin-taking patients are on a syringe and vial, and also on disposable insulin pens. As we know, insulin regimen is very complex. It can be very different things, different factors account between carbohydrates, your insulin on board. Insulin stacking can be a challenge for patients who are taking insulin with multiple daily injections. And one of the more common things that we see with patients on insulin is just a stacking of insulin can be one of the most common causes of low blood sugars. So having that lack of knowledge of insulin on board and personal insights for that insulin can lead to the stacking of insulin. So what we want to just introduce at high level is the InPen, which is the first and only FDA cleared smart pen. And what this is essentially is a pen that combines with continuous glucose monitors and an app for a smartphone. So basically tracking dosing, insulin on board, as well as other features to provide more information for the patient and also more for the provider so they can make smarter decisions on the insulin regimen. So these insights, again, database and reports can be helpful to provide input on active insulin on board, when the dosing is happening, and basically can replace the need for blood glucose logs as it does it digitally and via the application. And then finally, in studies, these are not head-to-head studies, these are individual studies just compared side by side. But if we look at the ADA guidelines for time below range, below 70 milligrams per deciliter and then below 55 milligrams per deciliter, we see the criteria here, and the InPen studies show that it meets criteria for both severe and moderate hypoglycemic recommendations.
Thank you, Emily and Brian. That's time, and appreciate your time.
Great.
Does anyone have any questions before we move on? All right. Next, we have Jennifer Draney from Utah Insulin for All. Jennifer, are you on the call? Okay, not hearing anything, so we'll move to the next person. We've got Roy Thomas from Dexcom.
Hi, everyone. Should I get started, or?
Yeah, go ahead.
Okay. And thanks for the time today. My name is Roy Thomas, and I'm a medical science liaison here at Dexcom. We are requesting that the Dexcom G6 be added to the preferred drug list and covered through the patient's pharmacy benefit. The Dexcom G6 is the only CGM that is available that is FDA approved as a replacement for finger sticks in patients as young as 2 years and older to make diabetes treatment decisions such as insulin dosing, diet, and lifestyle decisions. The American Diabetes Association considers CGM a standard of care for glucose monitoring in patients with type 1 and type 2 diabetes using 3 or more injections of insulin per day or using an insulin pump. The G6 is a real-time CGM where the device passively sends glucose information continuously to a receiver or display device without any action required by the user. The glucose information can also be shared in real time with up to 10 caregivers, with alerts and alarms provided to the user and remotely to followers when certain glycemic thresholds are crossed. This technology is essential for your members who are struggling with using their insulin safely and effectively, since they may be experiencing the complications of insulin treatment, such as hypoglycemia, or have an impaired awareness of hypoglycemia, which puts them at risk for severe hypoglycemia, which can result in an ER visit, hospitalization, or even death. For many insulin-using members, a real-time CGM with alerts and alarms and sharing may be the most appropriate CGM to protect the user and alert caregivers about dangerous lows or dangerous highs. The value of real-time CGM sharing and following or remote monitoring has been studied in a randomized controlled trial, which showed that parental hypoglycemia fear survey scores were lower while the child was using real-time CGM with remote monitoring. This has helped with parental health-related quality of life, family functioning, stress, anxiety, and sleep measures, which all significantly improved after the CGM intervention. Dexcom CGM has also been studied in randomized controlled trials across the lifespan to help patients improve A1C, spend more time in an optimal glycemic range, avoid hypoglycemia, and avoid those other complications such as hyperglycemia and the long-term complications of diabetes. And covering CGM through the pharmacy benefit will better allow patients to readily start CGM and safely and effectively use their insulin to avoid the complications of diabetes and its management. With coverage of CGM through the pharmacy benefit, a patient can start a CGM within days versus weeks through the DME channel, improving outcomes and reducing costs for Utah Medicaid. Thanks for the opportunity today to provide testimony.
Thank you. Thank you for that.
Hey, Brian, this is Joe. Can I ask a quick question?
Sure.
Dr. Thomas, intrigued by the sharing of the alerts. I assume there's a variety of different alerts. Does the system allow only notifies the physician, for example, of certain alerts and caregivers of other alerts? I assume that's customizable.
Yeah, so the alerts and alarms are customizable except for the severe hypoglycemia alarm. So that's when a person has a blood glucose of less than a glucose level of less than 55 milligrams per deciliter. Then that alarm cannot be changed. The other alerts can be customized for certain glycemic thresholds. And also there's a predictive alert where if a user is going to have a severe low within 20 minutes, the system alerts the user and the remote follower as well.
So does it, I guess I didn't make my question clear. Does every alert go to every remote follower, or can you customize it just so only some alerts go to one type of remote follower versus another?
Yeah, it's customizable. So the follower can choose to have certain alerts on. They can have them audible or vibratory or none at all. And each person viewing the glucose data can customize their alerts and alarms.
Great, thank you. Next up, we have Melody Tran from Abbott. Go ahead and turn the time to her.
Hey, Brian, this is, oh, go ahead. Melody's on. Okay, thank you.
Sorry, my mic was muted on the device, so sorry about that. morning, everyone. Thank you for the opportunity to speak with you today. My name is Melody Tran, and I'm the Medical Outcomes Manager for Abbott Diabetes Care. My goal today is to reinforce the clinical benefits of Freestyle Libre and the advantage of including it on the pharmacy benefit for type 1 and type 2 diabetes patients. Freestyle Libre has been associated with reductions in hypoglycemia, A1C, as well as hospitalizations and resource utilization. The Freestyle Libre 2 system is the only integrated CGM platform that measures glucose every minute through a small sensor that's worn on the back of the upper arm. A quick scan of the sensor allows the user to see 8 hours of glucose history, as well as their glucose trend arrows. The water-resistant sensor can be worn for up to 14 days and is the size of 2 stack quarters. Other notable features include that it measures glucose every minute, so it provides 5 times more glucose readings each day than other CGM systems. This is a safety feature we have that allows for the person to be notified within a minute that their glucose goes out of range. Also have accuracy over 14 days, and the glucose data can be used to make insulin dosing decisions without the need for finger sticks. It's indicated for management of diabetes in persons age 4 and older. And as Elena mentioned earlier, it has optional real-time alarms for hypoglycemia, hyperglycemia, and signal loss, which automatically notifies the user when glucose levels go beyond the target range set by the patient, or when the signal is lost without the need for scanning. The Freestyle Libre 2 sensor has a built-in transmitter, eliminating the need for an additional transmitter in order to provide these alerts. Freestyle Libre 2 has a mobile app that is currently under FDA review and awaiting approval. The mobile app has already been approved in Canada and the EU. A growing body of clinical evidence supports the use of Freestyle Libre, and I just wanted to highlight several clinical benefits. So in 2 separate RCTs, Freestyle Libre demonstrated about a 50% reduction in hypoglycemia compared with blood glucose monitoring for adults with type 1 and type 2 diabetes. In a meta-analysis, it was associated with an average A1C reduction of 0.55%, with results similar for adults and pediatrics in both type 1 and type 2 diabetes. In a prospective nationwide registry study, Freestyle Libre is associated with a decrease in the proportion of patients with diabetes-related hospital admissions from 13.7% to 4.7% in 1 year. The Freestyle Libre family of personal CGM systems is the most widely used CGM globally, with nearly 3 million users worldwide, and it's also the most affordable CGM at the lowest WAC price and at price parity with prior generations of Freestyle Libre, priced at 70% below the list price of other therapeutic CGMs on the market. We respectfully request for Freestyle Libre to be included for coverage for your members on the pharmacy benefit. And thank you for your time, and I'm happy to answer any questions you might have.
Thank you. Anyone have any questions for Dr. Tran?
Does the Freestyle Libre have a similar notifying remote users feature?
Yes, so currently the 14-day does, because it has the app approved. Once the Freestyle Libre 2 mobile app is approved, it will be able to be used with the app that can be shared with up to 20 caregivers.
All right, next up we have Nicole Lynch from the University of Utah Endocrinology.
Can you hear me?
Yes.
Okay, perfect. Let me just try and share my screen here. Hold on. All right. Are you able to see my?
Yes.
Okay, perfect. So my name is Nicole Lynch. I'm a nurse practitioner at the University of Utah, practicing in diabetes and glucose management. And I felt the best way for you to understand how life-changing continuous glucose monitors, or CGMs, are to allow you, through me, to meet some of my patients. So meet Maria. I met Maria as a patient in the hospital as she was testing her blood sugars approximately 6 to 8 times a day. When I asked her if she had ever looked into getting a continuous glucose monitor, her comment to me was that she thought her insurance, which at the time was Medicaid, would rather pay for a hospital stay than pay for something like a CGM. Her story was compelling as she was in the hospital with complications from diabetes, but this sentiment is often expressed both in the hospital and in the clinic. Next, meet Daryl. I met Daryl in April of 2020. He had used a continuous glucose monitor variably depending on his insurance. At one appointment, his insurance has switched to Medicaid and Daryl could not afford the out-of-pocket cost. He was on his last sensor and asked what he could do without one. I suggested that he needed to test his blood sugars at least 4 times a day and potentially as often as scanning, but Daryl was literally scanning up to 26 times per day. And he began to cry as this was too much of a burden for him and he knew it. The good news for Daryl is that his appeal did go through, which is not always the case, but he has been able to use the CGM to help improve his quality of life as well as help him qualify for knee surgery this week, actually. The top is what Daryl would see before a CGM, and the bottom is what he could see after. Of note as well, this data is approximately 2 weeks apart from each other. Next, meet Michael. I could talk about this patient for quite some time. Michael was diagnosed with diabetes in 2018 and has really struggled. This patient was admitted for DKA 16 times in 1 year, and these dates are listed here. Michael has type 1 diabetes, and insulin therapy is a must for him. He has had severe low blood sugars in the past and can't always feel his blood sugar dropping. This has caused him fear of low blood sugars and therefore aggressive treatments. I met Michael in October while he was inpatient and then was unable to get an appointment until the middle of November because he continued to be inpatient at scheduled appointment times. Per the prioritization team at the U, in order for this patient while on Medicaid to qualify for a continuous glucose monitor, he needed to have an insulin pump in place and documented chart note that he was testing blood sugar 4 times a day. By the time we were able to...
That's time.
Okay.
Does anyone have any questions for Nicole Lynch?
Nicole, do you find this technology is accessible to all of your patients?
No, I do not. So I would say it's probably like 25% of the time.
Thank you. That's what I was expecting. So it seems like it may not be intuitive or the best solution for all patients. So I was just curious what your experience there was.
Yeah, so I mean, I think that a lot of patients could utilize it. I don't know if my screen is still showing or not, but but it's not available to them. Like either it's too expensive or insurance won't cover.
So Dr. Lynch, this is Joe from Utah Medicaid. I'm sorry to interrupt.
Oh, no.
Go ahead.
Yeah, I was just going to say, but by accessible, Chris, did you mean that the patients can handle the technology, or accessible insurance and prescription or whatever wise? I think you may have meant like accessible technology wise.
Yeah, health literacy, technology, ease of use.
So, Nicole, if you want to answer kind of that side of the question.
Looks like she might be frozen. Let's give her a second. There we go.
Did I unfreeze?
Yeah, we can see you now.
Okay. I don't know if you heard. So as far as my patients being able to understand and handle the technology would probably be closer to 75 to 85%.
That's great.
So Dr. Lynch, this is Joe from Utah Medicaid. So Elena from the U presented various recommendations for the type of patients that would that should be qualified for CGM. Would you agree with those? Would you have different types of patients that should be allowed to have a CGM? Thoughts on that?
Yeah, so my recommendation would really be, I personally think the Libre and Dexcom both have great uses in my patients. But really for anyone who's on insulin therapy, I would recommend that they intensive insulin therapy, I'd recommend that they would be able to utilize a CGM. Then I would say, I know the question was brought up about pregnancy as well. Patients who are pregnant, I don't know how familiar you are, but they're asked to test their blood sugars up to 10 times a day. If they're following, well, 10 times a day is the standard, plus if they're feeling off, which is a kind of a large burden. So before meals and then 2 hours after meals. So I would recommend it's not as difficult currently to get pregnant patients coverage, but I would recommend it for them as well.
So for patients on intensive insulin, so you know, the classic basal bolus and then these gestational diabetes patients.
Correct. Mm-hmm.
Thank you. Thank you.
Mm-hmm.
We never did hear from Jennifer Draney. We have a couple of call-in callers that I can't see the names. Jennifer, if you're available, we'll give you another opportunity. If not, then we'll move on. All right, I don't see Jennifer Draney, so we'll continue with committee discussion. I guess to start things off, we really are looking to expand access for Utah Medicaid patients to continuous glucose monitoring products. And part of how we want to do this is through the addition of these products to the preferred drug list. And we've had some great presentation information, and so now we're looking for guidance as to maybe the direction to take.
Certainly, these products are equally safe and efficacious compared to, you know, our self-monitoring of glucose. And then I think, so in terms of kind of our traditional way of looking at products, they certainly meet that criteria. But then beyond that, I think the guidelines are helpful. And in terms of kind of guiding where we go with this, you know, it's clearly the people who are testing frequently, who are at higher risk for lows, that would get the most benefit. You know, there's a lot of heterogeneity around data for those who don't fall in those categories, and I think the benefit is really small for people who are, you know, for probably most of our type 2 diabetics who are on insulin, but there is certainly a chunk of people where there is a large benefit, and it really can be life-changing for those folks. And so I think I think that needs to be those would be my initial thoughts about kind of concepts that would guide us in implementing this for the PDL. And I think guidelines can, you know, the ones that Elena presented probably give us a good kind of baseline to work off of.
As part of this discussion, we'll also be reviewing these in DUR next month for the purpose of, you know, guiding prior authorizations. So we're looking at it from both angles.
I wholeheartedly agree, Clinton. One issue I had a little more granular as a pharmacist, these seem to have a smattering of essentially drug interactions, I'll call them. And I was just curious, Elena, if you are aware, has hydroxyurea been studied in all of them, or was that just caught in the Dexcom G6? And then tetracycline antibiotics, it seems like acetaminophen is an issue. I guess I was just curious how, as a pharmacist, you would catch these things. And I was concerned if anyone had experience with situations like that, because some of these are extremely common and some of them aren't.
Yeah, I just saw that in the user guides. I mean, they specifically mention drug interactions, but I mean, this is the information that I found there. So I guess there are no studies with, for example, for Dexcom G6. This is what we know about that. So I don't think there's more information about that, I guess.
Definitely, that was my feeling as well, as I was kind of looking through their package inserts. So I appreciate that. But that was one thing I couldn't tell if it was an error, omission or commission as to why certain drugs were on that package insert but not in others. So, thank you.
This is Roy Thomas from Dexcom. I can speak about the drug interaction, the drugs of consideration. So hydroxyurea is a known interfering substance. So what it could do is it could, a patient who is taking it would potentially have to confirm with a finger stick to make sure the CGM value is accurate. That's the only known interfering substance with the Dexcom G6. Acetaminophen was an issue with previous generations of the product, but it is not an issue with the G6. There's an acetaminophen blocking membrane, so it does not cause any issues with the sensor readings.
Thank you for that clarification.
Yeah, this is Melody from Abbott. I just wanted to add that there, for the Freestyle Libre 14-day and Freestyle Libre 2, there is no interference from acetaminophen or hydroxyurea.
Does Dr. King from Medtronic want to comment?
So we've had some discussion. Would anyone like to propose any motions with regard to preferred drug lists in these devices?
I guess I would just motion that these drugs or these monitoring systems are continuous glucose monitoring systems are equally safe and efficacious for inclusion on the PDL. I would recommend that devices that include alerts are available for pediatric patients be given preference. And then finally, just recommend that consideration for prior auth include need for frequent checks. I'm saying need for, not that they've demonstrated, but I would say need for, as well as frequent hypoglycemia or hyperglycemia with kind of high variability.
And perhaps we should separate that part out.
Yeah, that's more of a, I realize that last statement is very vague and more DUR kind of typical stuff. But I know a lot of people from DUR are here on this call, but So, you know, it might just get carried forward that way.
And maybe we start with the first two components and
those are the most clear, aren't they, Brian?
Right. Do you want to restate that just for clarity?
Yeah, so the first one would just be that continuous glucose monitoring systems are equally safe and efficacious for inclusion on the PDL. Kind of our standard language there, I think. And then the second would be that recommend including systems that have alerts for hypoglycemia and are available to the pediatric population. Did that cover kind of everything that people were thinking?
I think so.
Okay.
Do we have a second for this? It's sort of a dual motion.
I'll second both.
And who is that?
Cole.
That looks like, yeah, Cole.
Thank you. Okay, all in favor? Aye.
Aye. Aye.
Aye.
Are there any opposed? And does anyone abstain? Okay, looks like it's unanimous. Motion carries.
And then that second piece was more just, I don't think, just kind of getting at the point that I don't think we want to just say, oh, anyone should get a continuous glucose monitor, and kind of just some guidelines, recommendations towards DUR. And maybe we don't need to discuss that and really have a motion and a vote as much as just, I don't know, however you want to approach that, Brian, but I don't think there's evidence that says, oh yeah, just slap, anybody gets a CGM.
Right, right.
Patients want them because they're cool, but the benefit is low.
Right. Well, and I think that's why we're taking the two-tiered approach with the P&T and DUR, and
Sure.
That gives us some good guidance moving forward. And thank you.
And this technology is so rapidly evolving, seeing these patients in the ER just over the past couple of years. So
yeah,
I think we have to leave the window open for more advancements.
Absolutely.
Great. I'm going to have to step out early. I don't know if there's something before I jump away. I'm sorry.
I think we're just about ready to wrap up, unless anyone else has anything pressing. There's an error on the agenda. It says the next meeting is today. The next meeting will be in May, and we'll be discussing glucagon products. And if we can fit it in, we'd like to also do the reports from the ACOs and possibly our annual training on Open Public Meetings Act, but we'll see what we can fit in, and we may have to do some of it in our following meeting. But next meeting will be May 20th. Look forward to seeing everyone then. Do we have a motion to adjourn?
I'll move to adjourn.
Thanks, Michelle.
And I'll second.
Thanks, McKay. All in favor?
Aye.
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 All right. Thank you, everybody. Meeting adjourned.
Thank you.
Thank you.